Okay, a very good afternoon to one and all. And on behalf of the Department of Pathology and the Department of Gynae and Obs, AIIMS New Delhi, it's my pleasure to welcome you all to the Clinical Pathology Conference, which is a much awaited activity which we have every month on the last Tuesday. And this time we have a very interesting CPC case, which is involving some very interesting interaction between the Department of Gynae, oncology surgeons, as well as the pathology department. So I'll take this opportunity to start the CPC. And first of all, it's my real honor to introduce to the audience our clinical discussant for today, who is none other than Professor Sarita Shamsunder. She's a well-known gynae oncologist in all over the country as well as internationally. About her, that she is a consultant and professor at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi, right across the road. And she's an accredited colposcopist of British Colposcopy Society. Ma'am has been the immediate past president of the Indian Society of Colposcopy and Cervical Pathology 2018 to 21 period. She is a board member of the International Federation of Colposcopy and Cervical Pathology, and she had organized Asia's first IFCPC World Congress of Colposcopy and Cervical Pathology in July 2021, and I distinctly remember having participated and conducted a workshop in this conference. She's an executive member of Association of Gynae Oncologists of India, chairperson of the Oncology Committee of Delhi Obs and Gynae Society, AOGD 2325. She's a master trainer of the MP State Government Screening Program, and she's an academic coordinator of the DNB Gynae Oncology Program at Safdarjung Hospital and West Zone coordinator of the National Board of Examination PG webinars, which are a very important teaching activity for the postgraduates who are doing gynae, especially gynae oncology. So, ma'am, I welcome you and invite you here to conduct your discussion for the case. Now, I'm sure all of you have the histories which have been shared earlier via email. So, those of you who want to have a quick look, there are some copies kept here. And we now invite Dr. Sarita. Representative.
Good evening, everyone. Thank you so much, Dr. Mathur, for the kind introduction. Thank you, Department of Gynae, Dr. Nija Batla, Dr. Rajesh, for this invitation. This is the first time I'm being a discussant, so bear with me. Okay, the case which was sent to me was, the history goes as follows. A 27-year-old unmarried girl who is a resident of Haryana presented with a history of one episode of acute urinary retention and spotting per vagina for 1 week. History of present illness. 1 week ago, she had an episode of acute urinary retention for 5 to 6 hours and relieved after antibiotics for UTI. She gave a history of intermittent spotting per vagina for 4 days, which was very scanty in quantity and not requiring usage of sanitary pads. There was no associated fever, abdominal pain or vomitings, and there was no history of constipation or bleeding per rectum. Her menstrual history, she had attained menarche at 13 years of age, and her prior cycles were regular with normal flow 4 to 5 days in a 28 to 30 day cycle. And past history, there was nothing significant. Family history, she had a father had nasopharyngeal carcinoma on treatment, and maternal aunt had carcinoma of the breast. On examination, the findings were general examination. Her vitals were normal, and her weight was 45 kg and a BMI of 17.1 kg per centimeter square per meter square. There was mild pallor, icterus, cyanosis, clubbing, all that was absent. And thyroid and breast examination, there were no abnormal findings. Chest and cardiac auscultation was unknown. On local examination, per abdominally, there was no lump palpable and there were no findings suggestive of any free fluid. On gynae examination, which was done under anesthesia, the local examination, external genitalia were normal. On per speculum examination, a 5 into 4 centimeter proliferative growth was seen from the cervix, and per vaginal examination showed the same growth, which was arising from the posterior lip of the cervix and involving the adjacent posterior vaginal wall. Uterus was not felt separately, and per rectal examination revealed another firm lobulated mass of 6 into 8 centimeters from the anterior wall of the rectum, protruding into the lumen. There was no staining of examining pigments. And the investigations were as follows. Hemoglobin was 12.1, total leukocyte count was normal, and the differential count, platelet count was normal, and even the TSH was normal. And the LFT, the renal function test, electrolytes, blood sugar, everything was normal. Tumor markers, CA125 was slightly raised, whereas CA 99, LDH, alpha fetoprotein, beta HCG, they were all normal. Endoscopy, upper and lower GI, upper GI endoscopy was normal. Colonoscopy showed an extrinsic bulge at 10 centimeters from the anal canal, and the mucosa was normal up to the transverse colon. Now the imaging which was provided, this is the ultrasound upper abdomen, which is essentially normal. You can see the liver and the kidney, which is normal. There is no hydronephrosis. And on the cross section on ultrasound, so you can see the uterus here, and there is a mass in the left adnexa with shadowing. It's a hyperechoic mass. The same mass, you can see that it is bilobed with 2 components, and then this is the other one is extending into the POD. And the right ovary is seen clearly. And the cervix, lower down if you go, this is the cervix, cross section of the cervix, and this is the mass which is on one side of the cervix, and it may be arising from the wall of the cervix. The lower down if you go, you can see part of the cervix, and then the mass is on one side, on the left side of the cervix. So it could either be arising from the cervix, the lateral wall, or it could be just compressing the cervix and displacing to one side. And on Doppler, you can see that it is a relatively vascular mass. You can see this is a relatively vascular mass with arterial fluid. On MRI, this is a T2 image which is fat suppressed. So if it was a fat arising from the fat, this would also be suppressed. However, this is hyper intense compared to fat, and this is so it's unlikely arising from fat. And then T2 image from below upwards, you can see this is the vagina. There's no mass in the vagina. And going higher up, this is the cervix, and here the mass is actually lateral. It appears to be lateral to the cervix and compressing the cervix to one side. So this is on the left lateral, posterior and lateral to the cervix. Here also you can see going higher up, and this is the sacrum, and this is the presacral fat plane, and this fat plane is intact, and this is the rectum. So the mass is actually compressing the rectum and displacing it to one side. So it is lying between the cervix on one side and the rectum on the other side. So going higher up, this is the uterus, and the left ovary is also seen clearly, so it's not an ovarian mass. On sagittal section, the MRI, you can see that the uterus is fine, and this mass is actually displacing the anterior lip of the cervix. So the cervix is spread out over here, it appears to be, and this is the vagina. And this is the second part, this is the bilobe, the other part which is going posteriorly into the pouch of Douglas, and it is compressing the rectum. Now diffusion weighted image, if it's a malignant tumor, this appears hyper intense, and this is what is happening. So it's hyper intense, it appears to be a malignant tumor coming from the extraperitoneum. and the NCCT showing calcification within the mass. And this is the PET CT image, which is showing increased uptake. The mass is showing increased uptake here also. So in summary, she's a 26-year-old with a pelvic mass which is posterolateral to the cervix, which is either arising from the left lateral part of the cervix or it is extraperitoneal, and it is presacral, displacing the rectum. So the causes of the pelvic masses are either, first of all, we need to determine whether it's extraperitoneal or intraperitoneal. If it's an intraperitoneal, is it ovarian? Now this, because we could see the ovaries clearly, it's not an ovarian mass. Is it coming from the bowel? Now because the bowel is compressed, it is not involving the bowel wall, so it's unlikely to be a bowel mass. Now it appears to be an extraperitoneal mass, then we need to see which compartment it is coming from. Is it anterior, middle or posterior? Now here, because here it is coming, it was in the posterior compartment, or it could be from the fascia, the rectovaginal fascia. So it could be perirectal, unlikely to be rectal cancer because she has no rectal symptoms of any bleeding PR and the mucosa is intact. It could be retrorectal, and if it's arising from the rectovaginal fascia, it could be any of these metastasis, but there was no other tumor anywhere in the body, and it could be extra genital, extra gastrointestinal cyst. Is it a leiomyoma? Is it endometriosis? No, it seems to be more like a malignant tumor. So it could be a sarcoma also. So if you look at the pelvic spaces, so this is the bladder here, this is the uterus, and in between the two is a vesico-vaginal space. This is the vagina, and in between the vagina and the rectum, you have the rectovaginal fascia, and here surrounding the rectum is the mesorectal fascia. Surrounding the bladder is the perivesical fascia. So here there is a lot of loose areolar tissue, and you have these spaces: paravesical fossa anteriorly, pararectal fossa posteriorly, separated by the cardinal ligaments. And here you have the sacrum, and this is the retrorectal space. So the mass seems to be actually coming, is extraperitoneal. So it seems to be actually displacing the rectum, like depicted here, displacing the rectum and the cervix. So it's more likely to be extraperitoneal. So what are the extraperitoneal tumors which can arise anywhere in the pelvis? So it could be from any of these structures. It could be from the lymphatics. They are more likely to be cystic, solid tumors. They can come from the fat, lipoma, liposarcoma, or dermoid cyst. Or from the myxoid tissue, they could be myxomas, myxoid sarcomas. From the fibrous tissue, they could be leiomyoma, solitary fibrous tumor, or extra intestinal cyst. So extraperitoneal tumors in specific locations. So if it's pre-vesical, so it's mostly mucinous, so it could be urachal adenocarcinoma. Retrorectal, they are more likely to be cystic, tail gut cyst, rectal duplication cyst, epidermoid cyst, or meningocele. Solid tumors could be myolipomas. Along the nerve, there could be schwannomas and neurofibromas. So the common sarcomas are the liposarcomas, which could be well differentiated or dedifferentiated subtypes, or we could have leiomyosarcomas. Whereas the rare sarcomas are solitary fibrous tumor, inflammatory fibroblastic tumor, rhabdomyosarcomas, malignant peripheral nerve sheath tumors, extraskeletal osteosarcoma, synovial sarcomas, desmoblastic ground cell tumor, pecoma or perivascular epithelioid cell tumor, undifferentiated pleomorphic sarcoma, or extraskeletal Ewing sarcoma. So these are rare. So now in our case, this tumor is a large non-necrotic, because there are not necrotic areas, and it is homogeneously enhancing mesenchymal tumor with two components. It is vascular, appears to be malignant, and there is calcification. So the possibilities that we could think of are rhabdomyosarcoma of the cervix, retroperitoneal mesenchymal tumor, either a leiomyosarcoma, a fibrosarcoma, extraosseous osteosarcoma or liposarcoma, or it could be extra intestinal stromal tumor, that is gastrointestinal, extra gastrointestinal stromal tumor. However, these are rare. Now, rhabdomyosarcoma is a primitive mesenchymal malignant tumor with a tendency for striated muscle differentiation. It is more common in children, but however, it can occur in adults. So, in children, what you get is a vaginal rhabdomyosarcoma, whereas in the reproductive age group, you get cervical rhabdomyosarcoma, and in postmenopausal age group also you can get this tumor, and that is more likely to be in the uterus. So, it can have a varied presentation. So, there are three major histological subtypes: embryonal, alveolar, or undifferentiated. Now, the embryonal subtypes, you can have subtypes: classic, the botroid, or the spindle cell. But this usually presents as a polypoidal mass coming out of the vagina. However, it could be rare. Rarely 7% of them can be retroperitoneal. It is the prognosis is poor. About 50, the survival being only 50%. So the only factor in our case which suggests probably could be a rhabdomyosarcoma is the fact that it was arising from the cervical wall. Probably it's from the cervical lateral wall of the cervix. Now, extra-gastrointestinal stroma tumors. This is a very rare tumor. A total of 58 cases only have been reported in the literature. The histopathological features resemble those of the GIST, gastrointestinal stromal tumors. However, simultaneous neoplasm of the GIT should be ruled out. And on cross-sectional imaging, these mostly are well-defined, inhomogeneous. I mean, it's not homogeneous, but varied and heterogeneous, soft tissue masses with heterogeneous contrast enhancement. But rarely you can get homogeneous mass lesions also. The factor again, this goes against in our case was it's more of a homogeneous mass and the calcification and the fact that she had some bleeding per vagina. These are some factors which are going against. Could it be a leiomyosarcoma? The leiomyosarcoma, it shows intermediate high level intensity on T2 images and intermediate low intensity on T1. Now the signal intensity can be variable depending on the amount of necrosis, but small leiomyosarcomas are usually uniformly solid due to areas of necrosis and hemorrhage. Large tumors can have heterogeneous components. Now in our case, because fat suppression images, if it was a leiomyosarcoma, the leiomyosarcoma, here the hyperintense part, it is here, if it's coming from the muscle, it should have the same intensity as the muscle. However, this is hyper intense, so that could be one factor against. However, it may have, because large and it could be sarcomatous, they can have heterogeneous components. Now, is it a liposarcoma? Now, liposarcoma is the most common malignant mesodermal tumor, commonly seen in 5th and 6th decade. Here there is loss of fat signal. When you actually see a fat suppressed image, even the mass will show loss of fat signal. However, if they are dedifferentiated again, and if they could be heterogeneous, and calcification also is a sign of dedifferentiation. In our case, it could be because there is no fat suppression. It could be, but however, it could still be a high-grade liposarcoma, which could be dedifferentiated. Is it a lymphoma? Lymphomas are usually iso-intense on T1 images and iso to hyper-intense on T2. It is moderate, homogeneous or patchy enhancement after contrast, and it's a hypovascular mass lesion that spreads between the normal structures, and it can usually encases the abdominal aorta or IVC without compression of the lumen. So that feature suggests retroperitoneal lymphoma, but what goes against was the calcification, and it's usually submucosal and other lymph nodes are normal. So those are the possibilities that we could think of. So I thank our radiology faculty for their inputs.
Yeah, before I go to the audience for their inputs, I would like to, so what Dr. Sarita has basically nicely discussed, approached the case based upon whatever we have provided her, is that this was a young girl presented with a mass which was mainly pelvic in location with a externally encasing the rectum, and there was a component which was involving perhaps the cervix. Isn't that right, ma'am? So the possibilities which you have considered have been rhabdomyosarcoma, rare possibility of other sarcomas like leiomyosarcoma, liposarcoma, lymphoma, and of course extraintestinal cyst. So amongst, ma'am, these possibilities, may I ask you why you have not considered as a cyst? I mean, based on the radiological features, you have ruled out
Yes.
completely cyst because it was. Can you somebody give her a mic? Mic.
Could still be extra-intestinal cyst.
Extra-intestinal cyst. And amongst lymphoma is lower down in your possibility because of the reasons which you have already mentioned. So any other, ma'am, other lineage wise, if we discuss, one is possibilities a cyst, other is a sarcoma. Any other lineage wise possibility which would you like to consider, any other tumor or any other possibility?
Extraosseous
Osteosarcoma, again a mesenchymal, but yeah, bony tumor. So extraosseous osteosarcoma based on the calcification. And basically, yes, but neurogenic tumor. But then you were very sure, as I saw during the presentation, that it is a malignant tumor. There was no possibility of this being a benign tumor as such based upon the findings provided.
The neural tumors are shallow.
Yeah, ancient schwannomas and old ones, they can show calcification. But there was, I think, FDG uptake was there at the periphery of the lesion. It was enhancing on FDG. That was something difficult to explain based on that. And, so lineage wise, you would not like to consider anything like an infectious process or any other epithelial tumor arising from any place. Would that be a possibility?
Epithelial would be coming from the cervix or so because it was not compressing, it was not involving the human or the extrinsic compression. What you have
There was no bleeding PR. Fine. And then lastly, if you were to still narrow down your differentials, what would you put your money on? Which one or two diagnoses? That's always the thrill of the CPC. So I would like to really request you to, what is your most likely possibility or something like that. Or maybe you can give it a thought till I ask the audience also. So ek aur mic pe. Anybody wants to? Any other possibilities? Anybody? On the male side, on the pathology side, those who don't know that. Anybody would like to for a diagnosis? Yes, residents at the back. We have seen the presentation, it's like a case. Yes, after watching you have to be superficialist, think about the possibility. It is a young girl who presented with the maths, she was seeing all parts of the examination, like a growth rising of the cervix or the vagina, there are fornix. There was on imaging also a parallel. What would you think of this? Let me add something more. There was no ascites. There was some calcification of the aging. Possibility. Myoma. ovaries were normal or not, there is no seen on imaging as both ovaries inflated. Showed both images inflated. So I think both ovaries come to the dermoid. Well, why would a dermoid present as a visible for certain exam? It's difficult to explain. So when we come out of this, yeah, classification I agree, but dermoid scan just talking about image diagram or dynamic transformation. That is a possibility, but the ovaries, were very connected. Like extra ovarian, you want to say Johnson, maybe can be possible. Anything else? Primary? Rectovaginal septum. So, usually rectovaginal septum was what? Doesn't have a tumor rising from rectovaginal septum is also one of the popular sites for endometriosis. Tumor rising in the skin of endometriosis. Which you can be beyond for that. Think of that. So the procedure part of CIC is extra few endometrial stomas. Would we expect it to be low grade or high grade? Usually low grade. Okay, yeah, this apparently on the radiology there was no question. It was seemingly less circumspect except that lower down to the vagina. We might see. So that's a good possibility. The stomas. Anything else? There will be desmoid tumor. Okay. Desmoid tumor usually can occur as a death. Even tumor. They are usually, yeah, I would think that can occur as a death. In CBC is a fertile ground for their diagnosis. You are allowed to take widely. So that is a possibility. Ovarian is anything else? Yeah, you got a fair number of other optional diagnoses. So, turning out to be a very interesting discussion. And ma'am, if you would like to now, on hindsight, add anything to your list or narrow down or one. It could be a gist or a concept. So, yeah, after that, the possibilities which have been provided. Now, I will just briefly invite the clinical from the clinical side. Dr. Neerja is on here, I think. Dr. Ajay. So I would like to her to comment on how they worked up the case, kind of at this point in time when they first saw the patient and.
Good afternoon, sir. This patient presented as a history of urinary retention 1 week back and discharged on and off since 5 to 7 days. And came in the OPD. Then I have done her ultrasound. So during ultrasound on left side there is a solid mass. So I have sent her to radiology for further imaging. So in that imaging also there is 6 by 8 centimeter solid mass. So we have further send investigation, CBC LFT and tumor markers in which CBC CA125 is raised. Then we have taken her for examination under anesthesia, in which on per speculum there is a small 5 by 4 centimeter fleshy growth arising from cervix, mostly on left side. We have taken that biopsy and sent for her that histopathological examination. On per rectal examination, there is 6 by 8 centimeter approximately hard mass is there that is compressing rectum. So after this, we plan for MRI, and further after MRI to rule out other sites, we have done her PET scan. So, sir.
So first of all, I would like to invite our radiologist. Already Dr. Sarita has beautifully shown some nice images which have kind of highlighted the extent of the lesion, but I would like to invite Dr. Smita Manchanda and give her perspective about the radiology.
So a very good evening to all. Ma'am has shown most of the images already. So we can see that this is the uterus on the transabdominal scan, and we are seeing a large mass in the adnexa on the left side, which is appearing to having some degree of shadowing. There is an increased echogenicity, so we would like to call it as a hyperechoic mass with shadowing. On the ultrasound, this is the right ovary and this is the left ovary. The lesion appears to be separate from the left ovary, draped along the left adnexa. When we are seeing it in the sagittal, so this is the sagittal view where we can see this is the vagina, this is the rectum, and this is the cervix. And this is that irregular mass lesion. The definitions of the margins of the mass lesion are not well seen on the ultrasound, but we can appreciate that there is a loss of plane with the cervix and also with the rectum of this lesion. It shows a mild to moderate degree of vascularity and then low resistance arterial flow. In terms of the localization, so we can see that this is the uterus, part of the cervix, the vagina, and this is the rectum, and this is the localization of the mass on the sagittal. And on the axial, as ma'am had shown, that this is the cervix along with the Nipothian cyst, and this is the mass lesion, which is having predominantly a solid component. There is not much of a cystic component, which is appreciated on the ultrasound. So these are the upper abdomen images, which are essentially normal. So to summarize, on the basis of our ultrasound, we have a large mixed echogenicity mass lesion in the left adnexa and in the punctum ductus. The mass is predominantly solid with possible calcification in view of the shadowing that we are getting and with internal mild vascularity. Uterus normal, bilateral ovaries normal, no significant lymphadenopathy or ascites on the ultrasound. Then we went ahead and did the MR for this patient. So now these are the MR images. This is a T2 weighted image at the level of the cervix. So we can identify like this is the endocervix, which is hyperintense. This is the stroma of the cervix. So there is no signal change within the stroma of the cervix. So it is unlikely to be cervical in origin, even though the plane with the cervix is lost. So for example, this is the T1 weighted image. Here also we can see that there is a very ill-defined plane with the cervix. So there is possibly infiltration of the margin of the cervix, but no definite lesion within the stroma of the cervix or unlikely to be a cervical origin. As we are seeing that again, this mass is predominantly extending on the left side. Now this is the rectum. So this is the T2 weighted image, this is the T1 weighted image, and these are the post-contrast images. So here also we can see that this is the normal lateral wall of the rectum, and here we can see mild thickening of the wall of the rectum as well. Loss of fat planes of this mass lesion with the rectum. These are the diffusion and weighted images along with the ADC map. Bright on diffusion, markedly dark on the ADC, suggestive of restricted diffusion. Now, if the lesion is showing restricted diffusion, and it's a solid mass because it's T2 intermediate signal and it is showing heterogeneous post-contrast enhancement, so then the likely possibility is that it is a malignant mass. Either we can have a malignant mass which shows restricted diffusion, or it can be an abscess which has got liquefied pus which can restrict. The appearance is not at all like a abscess because there is no peripheral enhancement. It's not cystic, it's predominantly solid. There is one component of this mass on the post-contrast images. On the T2, they are appearing similar, the paracervical and the pararectal. So it's like a biconvoluted mass. The paracervical lesion is showing only a peripheral rim of enhancement. But when we are seeing the susceptibility weighted imaging, which is primarily to pick up calcification or ossification or bleed, so here we can see that there is loss of, there is a area of signal void. So these multiple areas which are appearing dark on the susceptibility weighted imaging suggest that there is calcification within the mass. So there is a component which is paracervical, which is showing some degree of necrosis that has calcification. more coarse calcification. The largest solid component which is showing this kind of a sepal or irregular kind of an enhancement, it is showing also some certain foci of calcification. Now in terms of the extent, so this was about lesion characterization. In terms of lesion extent, now this is the coronal image. So this is the uterus along with the endometrial cavity. This is the cervix along with the endocervical canal. So this is how the lesion is draping. It is arising from the left adenic side. It's extending below in the paracervical region on the sagittal, paracervical component of the mass, and a large component which is predominantly in the prerectal location. And this is minimal fluid in the pouch of Douglas. There were only very small lymph nodes. So there was one left external iliac lymph node and bilateral internal iliac lymph nodes. Imaging wise, we would not call them suspicious because they are very small in size and they have a maintained oval morphology. So mild ascites, no significant lymphadenopathy. Now here also we can see this is one of the vaginal fornix. So here the vaginal this lesion is extending into the posterior and the left vaginal fornix. So here we can, post contrast, we can identify the right fornix, but on the left fornix there is this mass lesion which is none. These are the post contrast abdominal sequences which show that there is no evidence of any metastasis either to the liver or the spleen, no paralytic lymphadenopathy, the kidneys are normal, there is no evidence of hydronephrosis. So this is the summary which we have already discussed, and the uterus and the ovaries were normal. So differential diagnosis in terms of the description would be that there is a malignant heterogeneous pelvic mass in a female with a large solid component which has certain calcification foci along with a large necrotic component which is in paracervical location with calcification. So our differentials would be that either the lesion is arising from the vaginal fornix and then secondarily involving the cervix, likely a sarcoma, rhabdomyosarcoma or some other malignant mesenchymal tumor. Or it's an exotic mass which is arising from the rectal wall where it can be a GI stromal tumor, or it can be a primary peritoneal malignancy in the pouch of Douglas and infiltrating both the vagina as well as the rectum.
Thank you, Dr. Smita. And now I would like to invite Dr. Shamim from nuclear medicine for his perspective.
I think we don't have the images. Can you please show the images? Madam की presentation में. Yeah. Anyway, people have seen the images. On the images, there was only one mass in the pouch of Douglas. That was soft tissue mass having a lot of calcification in that mass. And actually, the main, Dr. Rajesh called, we wanted to see any other lesion in the body. So 90% of our work done when we saw that there is no other lesion, there was the only lesion which was there in the pouch of the Douglas. So we were left with only 10% of the mandate. Sorry for the these images. We have not cropped it properly. This our resident has given like this. Anything we have to blame, we will blame only the resident because we will feel ourselves safe in that case. So in this way, we can see there is a large mass in this region showing metabolic activity. There was no other lesion in the rest of the body. Considering the age and every other factor, and both the ovaries were separately seen, I think the images are not seen in this. So in other images, the right ovary was showing the follicular cyst, sorry, left ovary was showing the follicular cyst. So we have not thought of the ovarian malignancy. Though the presentation was looking like that, it may be the calcification. So we thought of sarcoma, as most of the people in the hall has gone through that side. So our first differential was sarcoma, and then sometime calcified fibroid do show uptake. So we have also kept this one as a diagnosis, and then extra option osteosarcoma was another diagnosis for us. Thanks.
Thank you, Dr. Shamim. So now that we have had the entire perspective, so if anybody has a quick comment to make at this stage, otherwise I'll go ahead and show you the findings as we Sorry.
Because one page which is we put between trade and MR and ultrasound as to what is the diagnosis. The clinical condition was what was the cervical mass. We were very clear that it was not a cervical mass.
Not originating from the clinical radiologically, yes, I think sarcoma is the thing. Only point is, does classification lead us to anything else? Does it say that we should think of anything else? No, obviously we will not think of what it actually
No, I think the daily
Classifications are a component
So classifications.
retrospectively, but obviously when we speak prospectively, I think we will just ignore the classification or something. The site of the lesion is quite clear. It's an uncommon site for any tumor in this age group. But I think only what we have seen is some abdominal some sarcoma. But this whether we should give importance, presence of calcification, think of something else, really not sure.
There is so much of diagnosis seen usually. They're never that
I think,
solid.
Doctor, to answer your question, the classification in this case was fairly significant. It was not just that one-off classification which you get in as a part of a degenerative process. It was quite a significant component of the. So that's why, it's quite logical to think of scenarios where we get. Secondly, the other thing which was not clear in this case were whether these two masses were linked to each other or not. So the pouch of Douglas mass and the one encircling the rectum. So that was another thing. It was difficult to explain as just confined to these two regions, and the rest of the peritoneal cavity is not having any ascitic fluid or anything. So I think there are many kind of things which maybe we'll discuss this later once I discuss the pathology. Some more aspects, what could be the possibilities. So let me now go and on to the case, and I'll present it as the way we have encountered this, and to keep the continuity intact, I will just kind of tie the loose threads which all of us have so far discussed, and I will not take too much time for this. So she was a young female, unmarried, and she had an episode of urinary retention, spotting per vaginum for 1 week. So fairly acute symptoms. She attained menarche at the usual age group, a little maybe 1 or 2 years here and there. She had a family history of nasopharyngeal carcinoma in father and breast cancer in close relatives. If you look at her tumor markers, CA125 was modestly increased. The CEA was 1.53, 99 was 4.19, LDH was 215, not markedly raised at all, not raised at all in fact. AFP 1.42, not raised, beta HCG was normal. So there was nothing alarming about her tumor markers, which we usually do in such patients. So, and if you look at the per speculum examination, there was a proliferative growth seen arising from the cervix. On prima facie, it was arising from the cervix. Per vaginum, the growth was arising from the posterior loop of the cervix, involving adjacent posterior vaginal wall. On per rectum, the mass was felt in the anterior wall of the rectum, which was projecting into the lumen, but the mucosa appeared normal. On colonoscopy, there was an extrinsic bulge at 10 centimeters from the anal canal. The mucosa was normal up to the transverse colon. So apparently there was no rectal or colonic growth which was visualized. And on ultrasound, the viscera were normal, uterus normal, endometrial thickness was just about normal. And there was this mass in the pouch of Douglas with contents of query fat, as was reported on the ultrasound. And this was the imaging finding which have been discussed in great details. And there were apparently two components of the mass: cervical, paracervical, which was necrotic, and pararectal, which was solid with insectations. On PET CT, there was peripheral FDG uptake in this cervical lesion, which was contiguous to the mass in the pouch of Douglas, and the para-aortic nodes did not show any FDG avidity, and there was no other metabolically active. So the lesion appeared to be confined, even on PET, to this part only. These are some of the representative image of what Dr. Sarita and Dr. Smita have already shown. So as I said during our discussions which we used to have at this stage, the clinical differentials were strongly in terms of being the young patient. They were thinking and presenting as a cervical mass, the first presentation. So it was thought that if there is a possibility of it being a round cell tumor, like a rhabdomyosarcoma most commonly, or something like an AIIMS, PNET. We have seen such round cell tumors rarely in the cervix in the past. So we would sometimes like to think of these possibilities, and given the pararectal location, so the possibility of a gastrointestinal stromal tumor, either intestinal or extraintestinal, was kept as a differential. These were the two main differentials on which we worked upon at this stage. I don't think there was any other discussion, right, Dr. Rajesh? No, at this stage I'm talking about the real-time discussion which we were having at this stage regarding the same patient. So this was what we, so now it was logical to do a cervical biopsy, and I think a cervical biopsy was done at this stage, and this was the details which were mentioned. So it was labeled as cervical biopsy 1 and 2. We got two large good chunks of biopsy and the same findings which were mentioned on the form. Now this was the biopsy. As you can see, there is a squamous epithelial lining overlying, and underneath this squamous epithelium, it does not appear to have any degree of dysplasia or anything on the surface epithelium. So there was a dense inflammatory process going on here in the below the cervical mucosa. One more low power image showing the same cervix, and you can see that why this inflammation was there, because large chunk of it was ulcerated. There was ulceration, and there were some these inflammation, some necrosis, and blue looking tumor which was seen beneath it. So this was the necrotic part, entirely necrotic. There were some crushed cells which were barely preserved, and some part of the biopsy showed well preserved structures. So you can see this calcification which we have been discussing all along. There is a lot of calcification which is there throughout the lesion, and this lesion comprises of, now if you look at the preserved areas, there are these tiny papillary and glandular structures which are seen over here. So they are very, very small microglandular like structures and small delicate papillae which are being formed over here, and there is this intense calcification. So I will we did some markers here, but I will just discuss these findings towards the end. So the cervical biopsy, we suggested features of an adenocarcinoma with large areas of necrosis, and some possibility of a low-grade serous carcinoma was kept. Now this diagnosis did not was against all the thought process which was going on till now, and it was really difficult to accept this diagnosis. But all the same, we were pretty confident that we were not at all dealing with a mesenchymal tumor or a GIST, and morphologically we were very, very certain that this was a adenocarcinoma, but with some low-grade features like that there was no brisk mitotic activity on it. So intraoperatively, what they were found was, it's just a summary. More details will be revealed by Dr. Rajesh after my discussion. So mass lesion along the wall of the rectum which was contiguous extending to and infiltrating vaginal fornix. There was no evidence of ascites. Ovaries and tubes were grossly normal intraoperatively. So the surgical procedure which was performed was exploratory laparotomy, POD mass excision, infracoligamenectomy, peritoneal biopsies, low anterior resection of rectum, and primary anastomosis was done. So as this lesion was adherent to the rectum, you all know. So we got two forms. First stage, we got the entire specimen which they removed, the bigger specimen which was adherent to the rectum along with the rectum. So this was sent to us first for frozen. And if you will look at this form, they were so confident of the diagnosis that this was a GIST that we were asked specifically to do markers for GIST. So that's a kind of, and then subsequently we did a frozen section examination on this, and later on we received the rest of the other specimens which were the omentum, the peritoneal biopsies, the proximal distal donut of the rectum which was excised and anastomosed, the right and left pelvic group of lymph nodes, paracaval lymph nodes, etc. So all this was removed, and this was the gross specimen which we received for frozen. Now if you look at this specimen, it appears to be a large mass, It had this was the proximal end of the mass, this was the distal. Now this was excised in contiguity with the lesion extending from the rectum along with the small portion of the rectum and right up to the vaginal fornix. So the attempt was at the distal end was to try and get a free margin of excision along the vaginal mucosa. And over here it was the proximal end. So this was more or less, the free end of the specimen, and here the rectum, the distal end of the rectum was behind this. So this is the unopened specimen as yet. So you can see it measured about these dimensions, and there was stapled ends at both. So now I have cut open the specimen. Now what do you see? If you look at this specimen, it was a well circumscribed. Now this is the cut open. This is the main bulk of the mass. As you can see, this is one half, this is the other half. So as you can see that on cut section, it is gray yellow with few necrotic areas. Now one of the end, there was a very, very scant margin. So it was only around 0.3 millimeters or something. And the proximal stapled margin was far away. And this was the rectum. This is the unopened rectum and the mass. And this is now which has been cut open. As you can see, the mucosa appears absolutely unremarkable. And this mass was on the posterior aspect of this excised rectum. So if you are to summarize some findings at this stage, this was a young female, mass adherent externally, appeared contiguous till vaginal fornix. There is no evidence of peritoneal nodules intraoperatively, and biopsy was suggestive of a low-grade adenocarcinoma. So differential from the pathologist's perspective, of course, why not? I would like to keep a low-grade serous carcinoma as my first possibility, since it's arising at a very unusual site, very primary peritoneal in origin. Second possibility, because there was a cervical component, one should always keep endocervical adenocarcinoma. This is not the age group for an endocervical adenocarcinoma, but as a second possibility. And of course, since there was a peritoneal component, why not a mesothelioma, which surprisingly nobody thought of. So a mesothelioma as a possibility, because remember, mesothelioma can also show glandular patterns, papillary patterns, and it can mimic an adenocarcinoma. Now these possibilities were completely ruled out. We were confident that we are not dealing with any round cell tumor, including rhabdomyosarcoma or any mesenchymal tumor or GIST for that matter. So this was the frozen section. The entire specimen was sent, as I told you, and we could take sufficient section, and it kind of consolidated our diagnosis of an adenocarcinoma with marked pseudomatous calcification. And now I will take you through some of the pictures of this case which we saw. Yeah, so if you can see at a very low power, what you see here is the rectal mucosa. Okay, this is the normal colonic mucosa, this is the submucosa, and this pink structure you see is the muscle layer. So this mass was sitting on the external aspect or the serosal aspect of this dissected rectum. As you can see in this particular image, you barely see any kind of a infiltration into the rectal mucosa. So there is a dense fibrous band which is there on the serosal aspect, and then there is this lesion. Okay, and if you go on to the rectal mucosa, the mucosa showing normal colonic glands, there was some lymphoid follicles, etc. Other than that, there was nothing much in this. So I will go to another image to show you the more details of this lesion. So why I have kept this image? This image I want to show you something that in other sections, you can see over here, the muscularis. Initially we thought there would be no infiltration, but now we started seeing these kind of infiltration which is present in the form of LVI as well as infiltration, small tiny tumorlets within the muscle layer. Can you see this? Same glandular structures which are present in the muscle layer. So there was apparently some infiltration into the muscularis as well. And now this is the section where I will show you the features of this tumor. This is a section which you can see is taken from the bulk of that mass lesion, solid firm mass lesion which was there. And this is the actual picture of the tumor. As you can see at this slightly lower magnification, there is a lot of calcification happening throughout the tumor. So all these dark magenta colored or pink colored structures, these are calcifications. And then there are these tumors which are arranged in glandular, small, tiny papillary clusters. There is some fibrotic stroma around these, lot of fibrotic stroma. And there is plenty of these tumors. Now, if you look at this tumor at a higher magnification, what do you see? You can clearly see a papillary architecture. But if you look at the nuclear features, they are very monotonous and bland looking nuclei. If you try to hunt for mitosis, you would barely catch one odd mitosis here and there. Other than that, there was no mitotic activity in this lesion. So, and there was nothing other than, it was not as if it was a biphasic tumor or anything, and this was the entire tumor which we had. And there was some kind of a fibrous capsule around the tumor. I have already shown you its relation with the tumor. So this was clearly a papillary adenocarcinoma having low-grade nuclear features and a very dominant papillary pattern and calcification. We are as pathologists, we are very familiar with this kind of an appearance, being that of a low-grade serous carcinoma. But the only thing which was tough here was to explain why it is its association with the rectum. That was the difficult part, as it was for the clinicians. So even for us pathologists, it was also not a very easy diagnosis to digest. Lastly, I will show one last scanned image. This was the omentum. So initially we took multiple sections. In fact, we thoroughly sampled the omentum, and what we found was that the omentum was clean. There was nothing in it. There were some of these kind of deposits, but these we thought were not actual metastases of this tumor. This was, as you can see, these are showing quatry artifacts. You know, these are burnt out epithelial structures. So these are probably parts of the quatry which were, kind of dropped in the omentum. They are nothing to do with actual metastasis occurring. So thereby we gave a note saying that this omentum was likely to be free, as there is no desmoplastic reaction around them, any inflammatory reaction around them, and these were just kind of present just like that. So the omentum was probably free in this case, and these deposits were just floaters. So I think with that the morphology is pretty clear, and these are some of the still images of the case which I just showed you. So you can see the beautiful papillae. These are the psammomatous calcification. Psammomatous because they look like these calcospheroids which you see in prostate or some other gland. There were beautiful glands, monotonous nuclei, hardly any mitotic activity. In fact, it is very, very difficult to find a mitosis. Some of the nuclei look grooved in appearance. This is another appearance of this calcification at a higher magnification. And these were some of the other things which I want to show, this relation of this tumor with the rectum. And you can see that the tumor is infiltrating to the muscle, and LVI were seen in the submucosa and muscularis mucosae. So this is the rectal mucosa which was free indeed, but in the submucosa there were some tumorlets in the vascular spaces. And this was the omentum which I already told you. And the right and the left pelvic lymph nodes were involved, 1 out of 2 in the right and 1 out of 8 nodes in the left pelvic group of lymph nodes. You can see this tumor deposits are there within it. And this was the resected end posterior cervical tissue and vaginal margin, which was unfortunately positive because it was very difficult to get a clean margin. As you can see why, because this is the intact vaginal mucosa, and over here the lesion is infiltrating and ulcerating the vaginal mucosa. So there was so this is the lower power. You can see only this part was intact, rest of it was all ulcerated and infiltrated by tumor over here. So now we come on to the axis. Now the next part is very simple for us. We just need to prove that it's a low-grade serous carcinoma. So we did a PAX8. PAX8 is a pan-Mullerian marker which indicates that this tumor is originating from the female genital tract. We did a P16, and the reason was mainly to rule out the possibility of an endocervical adenocarcinoma. So this was patchy positive, there was not a diffuse kind of a positivity. WT1 was diffusely and strongly positive, calretin was negative, thereby ruling out the possibility of any rare possibility of a mesothelioma as such. CK7 was strongly positive, 20 negative as would be expected in this case. And this combination of a strong WT1 positivity and a P53 which was wild type Wild type, why? Because it is showing nuclear positivity, which is moderately intense. In patchy, there is a large component of the tumor which is negative. So this is approximately around 40 to 50% staining, and that too not a strong and intense staining. Thereby it is a wild type, so it's not a mutated P53 mutation. That's very important to document, because if you get P53 mutation, then it's a high grade serous carcinoma. And Ki67 also consolidates that fact, because Ki67 is quite low in this case as compared to what you would get in a high grade serous carcinoma, which would completely light up the slide. Generally, in such low-grade serous carcinomas, we also do ER and PR. As you can see in this case, strangely, the ER was positive, but only weakly and in lesser percentage of the tumor, whereas the PR was very strongly positive. And this was the distal donut. Now, this distal donut we thought was negative, but again, over here, you see this tiny speck of blue. I have magnified it, and you can see there is a small LVI which is sitting there in this. So, other than that, it was clean. There was nothing tumor deposit as such, but the vascular space was involved in this. The proximal donut was clean. The right peritoneal biopsy was free of tumor. Paracaval and pericaval lymph nodes were free of tumor. These were the specimens which were completely free of tumor. We also did in our department KRAS and BRAF mutation profiling of these tumors. So these are the exons on which the mutations were detected, and there was no mutation found as far as KRAS was concerned, and even BRAF we tried to do on the following exons, and there was no mutation detected at any of the codons. So this did not show KRAS and BRAF mutation. So to summarize the findings, clinically this was a pelvic peritoneal mass lesion extending from rectum to vagina. Microscopically, I've already shown you the features. These were the positive markers, these were the negative markers, and molecular tests done on these both were negative. So the final diagnosis which we made in this case was a serous carcinoma, low grade. Now, because there was no visible nodularity or microscopic deposits as such in the rest of the peritoneum, this was possibly primary peritoneal. Second reason for it being considered as primary peritoneal, although we cannot be certain, that's why I said possibly, reason being that for a diagnosis of primary peritoneal, you need normal ovaries and fallopian tubes, which we could not document because those were not removed. But from the imaging, what we can see is there was no enlargement as such. So if you look at the tumors of the peritoneum, you have this low-grade serous carcinoma of the peritoneum which is reported, and then the mimics which I have highlighted with the red arrow are these papillary mesothelial tumors or a mesothelioma. So quick review about this is that low-grade serous carcinomas can show a variety of patterns. They usually lack significant mitotic activity. Psammoma bodies are frequent. Necrosis is rare, although we did see in our case, and they are commonly associated with borderline serous tumors. Now, interestingly, looking at the pathogenesis, they arise. So why you can get in the same tumor in the peritoneum as in the ovaries? Because the germinal epithelium lining both the organs is the same. There is currently no evidence to suggest that fallopian tube is the origin of low-grade serous ovarian and primary peritoneal. So for low-grade, fallopian tube is not the site of origin. They may exhibit KRAS, NRAS, BRAF, USP9X and EIF1AX mutations. High-stage tumors are less frequently associated with BRAF mutation, and KRAS mutation, when it is seen, is associated with tumor recurrence. Both were not seen in our case. So the MAP kinase pathway plays an important role in the primary peritoneal serous carcinomas, and KRAS and BRAF mutations are upstream regulators of this pathway. Another IGF-1 is frequently, insulin-like growth factor 1 is frequently overexpressed in low-grade serous compared with serous borderline and high-grade. And activating mutations of PIK3CA are also detected in 40% of the tumors. So these are the differences between high-grade. High-grade is, signature for high-grade is the TP53 mutations. They may have BRCA1, BRCA2 mutations, P16 overexpressions, and these I've already enlisted as the. If you do immunohistochemistry, I've shown you most of the immunohistochemistry, except that HER2/neu positivity is seen in approximately 30% of the cases. In our case, we did do a HER2/neu, it was negative. And about the ER negativity, I found an explanation for that primary peritoneal serous carcinomas are more frequently negative for ER. They are PR positive. So that's something which kind of corroborated with our findings. So you have also primary peritoneal low-grade serous carcinomas, and they do not present any specific symptoms. They may arise de novo or associated with serous borderline tumors. So this is the WHO criteria that you should have nothing in the ovaries, but there are other criteria which allow some amount of tumor in the ovaries, which is less than 3 or less than 4. But the central dogma for this diagnosis is that the peritoneal involvement should far exceed the ovarian surface involvement. That's very important. And grossly, they may present as multiple nodules in the peritoneum and omentum, which was not the classical presentation in this case. Microscopy, I've already told you. And you have to document gross and microscopic involvement of the ovaries. If it is there, then it excludes this diagnosis. The FIGO staging is same for ovary, fallopian tube, and primary peritoneal. So this was a stage 3A tumor. The disease course is that the patients, they have frequent recurrences and persistent disease which progresses even after completion of primary treatment, which is surgery. It shows a very low response, which is expected given the low proliferation index in this tumor, and the presence of KRAS mutations indicate an adverse prognostic factor, which was fortunately not there in this case. And it is staged as per the system applicable to ovaries and fallopian tubes. Now there are some differences. One of the largest series which have been reported in the world literature by Kathleen Schmeller et al. In the Annals of Oncology, where they studied 53 patients of low-grade serous. And what they concluded from the study is that similar to low-grade serous ovarian patients with low-grade primary peritoneal serous carcinoma, high rate of persistent disease at completion of primary treatment, but they have a long overall survival. So overall survival is very good, but they have frequent recurrences. In their series, I found that stage 2 disease, which means the disease restricted to the pelvic peritoneum, was only one case. So our case was probably majority part of it was restricted to the pelvic peritoneum, which was itself a very rare thing. And this is another studies in which they looked at the impact of age and primary disease outcome in women with low-grade serous carcinoma of the ovary. This was a very large study of 350 eligible patients. And they also concluded that patients with low-grade serous peritoneal carcinoma seem to have a better prognosis than ovarian low-grade counterparts. In this study, it was a similar kind, but they did not separate the high-grade and the low-grade serous carcinomas. But even they showed that the primary peritoneal had poorer outcomes as compared to the tumors in the ovarian loop. So, if you look at the molecular biology differences between primary peritoneal and primary ovarian, MAP kinase pathway plays an important role. There's a higher expression of HER2/neu, so as compared to primary ovarian cancer, low grade, and higher proliferation index. So even the Ki is slightly higher than a typical low grade serous carcinoma of the ovary. Lower expression of ER, which we found in our case, and the P53 is similar. So the unusual findings in the index case was presence of disease limited mainly to the pelvis, absence of nodular deposits, single solid mass-like lesion, which is, I could not find any example of such a large mass-like lesion being formed. So it was very, very unusual in that regard. Adhering and infiltrating rectum from serosal aspect. And so if you look at these reporting guidelines to establish the primary site in tubo-ovarian high-grade serous carcinomas, it does not apply to low-grade serous carcinoma. So all the guidelines exist for high-grade, but they do not exist for low-grade serous carcinomas. So quick word about the treatment. Surgery is the mainstay of treatment, debulking surgery. Although they are chemo-resistant, but almost all of them receive adjuvant platinum-based chemotherapy, which is a standard of care for low-grade. Maintenance therapy of hormonal maintenance therapy with aromatase inhibitors and leuprolide acetate, etc., results in improved outcomes. So maintenance, most of these patients are kept on maintenance. That's why the need for ER/PR. HIPEC has not become a standard of care yet, but there is enough evidence to support this integration in epithelial ovarian cancer, including low-grade serous carcinomas. And there are clinical trials which are going on for targeted therapy in these tumors. So lastly, these are rare tumors bearing similarity to their ovarian counterparts. And primary pelvic low-grade is extremely rare, and presentation as a solid mass is very, very uncommon. There are no reports of this presenting as a mass lesion adhering to rectal wall that I could find. Cytoreductive surgery is mainstay. Cytotoxic response to cytotoxic chemotherapy is poor. And despite frequent recurrences, they have a prolonged survival. Overall survival is good. There is limited data on pathogenesis, which I have already told you about. And ongoing clinical trials and studies on larger number of cases is mandated for better understanding and newer targets of therapy. So that's all from my side, and I acknowledge the help of my departmental and colleagues from the gynae department for their close interaction and help in this case. And it was a real eye-opener and a learning experience for me as well. And
There is no peritoneal.
yeah, so we don't know it will be arising from above or that part. Exactly the origin, ma'am, we could not delineate. But yes, I am going to call him. Yes. The discussion is not yet over. So, Dr. Rajesh, a quick word from you, then I'll call Dr. Bhu. So finally, if you would like to show, maybe both of you can come and since you are both involved in the surgery. Dr. Bhu.
So there was dilemma ki what we should do in this case, because there is a rectal mass 6 to 8 centimeter and firm to hard. So we have discussed MR and PET finding with Professor M.D. Ray sir, and with the help of sir, we have made a team with the Professor Nisha Batla ma'am, Dr. Seema Singhal ma'am, and sir was there for surgical oncology side. And we proceed with exploratory laparotomy, peritoneal wall cytology, and POD mass resection with the infracolic omentectomy, peritoneal biopsy, and lower anterior resection of rectum and primary and osmosis were done. So, sir, please.
Good evening, everybody. Time is, I think, short. So, what happens, because this is an exceptional, rare, and challenging case, no doubt about it. But what my belief is there, being oncosurgeon, this kind of big mass, when everybody getting confused, like from the clinician, radiologist, even the pathologist also, in that case, without getting delayed, I think we should do the surgery earlier. And that is my personal observation, because she is a young patient, but that surgery should not be in hampering the quality of life of this kind of young girl. So I mean the fertility preserving, rectal function preserving. So that kind of large mass was there, but truly speaking, because from the audience, from the expert, we came to know there is 10 to 15 kind of diagnosis. All I just know. For that I didn't make a comment because we didn't have that kind of points in favor of any diagnosis. So in that confusion, I think the surgery is the mainstay of treatment. Any solid tumor, you should do the surgery earlier. So that would have been the better. And particularly in this case, I see that is large mass was there, and particularly the rectum, mid rectum was involved and slightly infiltrated to the cervix and part of this vagina. We have taken the cuff of the vagina properly, and we repaired the cervix also properly. But it seems to be like a gist kind of thing is there. But I have not confirmed, but as per our experience, it feels like a gist sort of thing is there. But we can't believe like that is epithelial ovarian cancer. But we all know that abdomen is a Pandora box, could be happen anything, and that mostly fits in the pelvic tumors. So that's all, but she is doing good. We hope she will survive much more better. Thank you very much.
Thank you, sir. Now I would like to invite Seema ma'am for her opinion regarding this case.
Thank you, Rajesh. It was very challenging starting right from the pre-operative preparations because she was a very close relative of our faculty colleague. And so we were all very, very concerned with her. And it was real diagnostic challenge. When we examined her for the first time, finding out the rectal mass was just an incidental diagnosis, just doing a routine rectal examination. When we first examined, she complained with spotting. So we did a one finger PV because she was unmarried, but when we explained and she agreed, we did a one finger PV, we found a necrotic root. So we both thought, me and ma'am was there, and we thought it is rhabdomyosarcoma. Done. As a routine, it is for the benefit of the residents here. As a routine, we do PR for every onco case, and when I did a PR, we found that alag se ek mass pada hai. So it was like, what is this now? Which mass is this? And we thought maybe a cervical malignancy which is going into ovary, and an ovary is kind of that mass because of its weight sometimes sets into the POD and then it is coming down. But gradually as the imaging were done, and then as Dr. Ray said, Pandora box started opening up. And it was like what it is. And then intra-op also, with the help of everybody, ma'am was there, and then it was like, surgically, the most important aspect which we faced on the table was how to preserve our fertility, whether to preserve it or not. That was the real question, because the biopsy was there, and had already told us that it was a low-grade serous malignancy. But now the ovaries were normal, and the disease was like kind of going into the vagina and the cervix. We literally shaved off the cervix, and stitched it as well. But then leaving the ovaries and uterus in place, and especially in a low-grade serous cancer, I mean, it was a little bit concerned. And but then on the table, all the experts thought that let's leave the ovaries aside and let's give the fertility preservation option. And Dr. Ray at that table said, okay, we can come back again on her if required. So let us give her a chance. So it was like challenging from starting from the examination till the management. And in fact, post-operatively also, she was very well managed by the surgical oncology colleague regarding her bowel and everything. And now coming from Dr. Sachin regarding her adjuvant therapy, because nothing goes complete without that. Yeah.
Thank you, sir. And a very interesting presentation, sir. Actually, very nicely outlined regarding low-grade serous carcinomas of peritoneum and ovary. So it's a rare case. It was a rare case. If I'm not wrong, there was one more case where we had a abdominal wall nodule or mass, which was resected. Ovaries and uterus were left behind, and that was also low-grade serous carcinoma. But that was abdominal wall, and it was not sure from gynae side. I think it was with.
She had a delivery also.
Yeah, exactly. I think so. So it's probably the second case we have seen a low-grade serous carcinoma, not in ovaries. I'm not sure whether it was in peritoneum or not. So we have two cases now. Maybe it can be a case series or something like that. So regarding adjuvant treatment, low grades, they are very chemoresistant. Dr. Mathur has already outlined. Practically, there is no role of neoadjuvant chemotherapy. Response rates are 4 to 10%. For this patient, we will do whatever we can do because she's a young girl. We'll be giving chemotherapy. She has already received 3 cycles of chemotherapy, and we will also give her hormonal therapy because we know they are chemo-resistant. It's ER negative, patchy positive, and PR positive. So we will be giving her hormonal therapy also, probably for 5 years. There is no data whether 2 years or 5 years is there. And for in future, what we can do for these tumors for low-grade serous which are inoperable upfront, we can. There is some data with fulvestrant and abemaciclib, which has recently come. It had decent response rate. So that may be the strategy for other patients, or if any patients of low-grade relapse or something. As of now, she has received 3 cycles and will continue for 6 cycles and then hormone.
Thank you very much. And I think we have far exceeded the time. So, yeah, Dr. Ray, please.
One important thing, I was very much about the diagnosis of this. We have sent the presentation to Professor Mathur. He was so confident that this is low-grade ovarian cancer. We just completed the same procedure, but the team had for him on. He diagnosed.
And Dr. Mathur said, no, it is low-grade.
Yes, Dr. Singh.
Pathologist regarding parts. Give us the microscope and we'll pathology so much today. We have a whole lot of
Thank you so much for those kind words. It's actually a teamwork, and we all work together as a team and learn new things. Some things you learn from us, some things we learn from you. So it's a really an interesting interaction. Thank you so much to everybody for having patiently listened to this.